and welcome to the first of a brand new series of CSF podcasts focusing specifically on axial spondyloarthritis. We'll be bringing our new episodes on a bi-monthly basis, and we'll also be supplying you with monthly slide decks to help you keep updated with the latest research and publications in the field of r-axSpA. First of all, allow me to introduce myself and my co-host. I'm Sofia Ramiro from Leiden University Medical Center in the Netherlands. And today I'm joined by Hideto Kameda from Toho University in Japan. Hideto and I are new members of the CSF Steering Committee, and we're really excited by to be joining the wider CSF Steering Committee. If you want to find more about us, our bios have been added to the website, so you can head over to the cytokinesignaling.com and take a look.
Thank you, Sophia. The papers we'll be covering today both discuss structural changes as determined by MRI imaging, and both are by Professor Walter Maksymowych. Our first paper looks at the impact of Izikisumab on ASAS40 response in patients with radiographic r-axSpA after 16 weeks of treatment, while our second looks at the changes in total erosion, total backfill, total fat metaplasia, and total ankylosis scores in sacroiliac joint after 12 weeks of filgotinib treatment.
So, over to our first paper entitled Izikisumab in radiographic axial spondyloarthritis with and without elevated C-reactive protein or positive magnetic resonance imaging. As you know, in patients with radiographic axial SPA, when they have persistently high active disease and insufficient response to NSAIDs, they are treated with targeted biologic interventions, for example, TNF inhibitors and IL-17 inhibitors. And nowadays, these can also be expanded to targeted synthetic DMARDs like JAK inhibitors, which are also approved for the indication and have shown efficacy. Patients' response to treatment has been shown to be influenced by elevated CRP levels and evidence of inflammation on MRI of the SI joints. So the aim of this study was to evaluate responses for Izikisumab at week 16 in patients with radiographic axial SPA by evaluating CRP and spinal and SIJ MRI for inflammation. Data was used from two randomized double-blind placebo-controlled trials, the phase 3 trials with Izikisumab, COAST-V and COAST-W, in which patients were biologic naive in the COAST-V and previously treated with 1 or 2 TNF inhibitors in COAST-W. All patients had the diagnosis of radiographic axial SPA, fulfilling classification criteria, and patients had active disease as defined by a BASDAI of at least 4 and spinal pain of at least 4. Patients were randomized to receive 80 milligrams of Izikisumab every 2 weeks, or 80 milligrams of Izikisumab every 4 weeks, or placebo, or another arm that was an active reference with 40 milligrams of adalimumab every 2 weeks. In this only in the COAST-V, so in the biologic naive patients. At week 16, so the timing of the primary endpoint, patients that were already receiving Izikisumab continue assigned to it, and patients that received placebo or adalimumab were randomized 1-to-1 to Izikisumab every 2 weeks or Izikisumab every 4 weeks through week 52. And the key endpoint was ASAS40, and we will look at it stratified by the presence of positive or negative baseline CRP and positive or negative baseline MRI of the spine and the sacroiliac joints, in which the SPARC was used and stratified by a cutoff of 2. And when we look at the individual results, so more than 500 patients were included, almost 600 in both trials. And when we look at the results stratified by CRP, so we see a higher numerically higher response in patients with Izikisumab compared to placebo, both in lower and higher CRP groups, whereas in the group with the positive CRP, there is a statistically significant difference between the Izikisumab arms and placebo, also a statistically significant difference between the adalimumab arm in COAST-V and placebo. So this was similar in both trials. And when both trials were pooled, so a higher number of patients was included in the analysis, and then also in the group with negative CRP, there was a statistically significant difference between the arms of Izikisumab and placebo. So actually we see a higher response with Izikisumab compared to placebo, both in groups with negative and with positive CRP. Then later, the authors also looked at the predictive value of the CRP when in a logistic regression, and there it did not seem to be predictive of response of an ASAS40. Then moving down to MRI and looking at MRI of the SI joints, which could only be performed in COAST-V, we see a statistically significant different response, so higher response in both Izikisumab arms compared to placebo, in both groups with a negative MRI and with positive inflammation on the MRI as assessed with a SPARC score of at least 2. The same was obtained when MRI of the spine was analyzed in COAST-V, not in COAST-W, and COAST-W is the trial that included patients that had already failed TNF inhibitor. So, and when the authors looked at the predictive response of MRI, this was predictive in COAST-V, so in patients who were naive to biologics, both MRI of the SI joint and of the spine were predictive of a response. So interestingly, we see here that Izikisumab works in both groups, in patients that have signs of inflammation and patients that do not have signs of inflammation as measured by positive CRP, and inflammation mainly in the SI joints, and also assessed inflammation in the MRI of the spine. We see numerically higher responses in patients that have positive signs of inflammation. This is in line with what we had seen before, also with studies from TNF inhibitors. Surprisingly here, we do not see CRP as a real predictor of response, and we also see positive response or higher response in Izikisumab, even in patients with a negative CRP. So there are here some important findings that are different to what we had seen before with TNF inhibitors. Maybe there is a different mode of working of the IL-17 inhibitor. It would be interesting to also confirm these results with another IL-17 inhibitor to understand whether these are compound specific or whether these are specificities of these trials that were also more recently conducted. I don't know whether you would like to add something on this, Hideto. What's your view on this?
Okay, thank you. This study is a predominantly subjective ASAS40 response versus objective baseline CRP or MRI was examined. Then, how about the correlation between subjective response such as ASAS40 and objective response such as MRI improvement?
Yes, definitely. I think that's a very important point that you're mentioning.
Yes, and a little bit higher response of ASAS40 when based on the objective signs or symptoms, so higher CRP or higher MRI inflammation, right?
Exactly, with what we are used to seeing, and therefore we also we mainly recommend treating patients that have active disease and that have one of those components of inflammation objectivable.
Yeah, but still the patient with less CRP or less MRI inflammation showed a good response to Izikisumab. That's very important information for us. One limitation may be MRI inflammation was not assessed by SPARC scoring system as described in the paper, right?
Inflammation was assessed by the SPARC, and then it was stratified according to the cutoff of 2, which is usually the cutoff defined to define the absence or presence of inflammation. The issue, I think, with limitations is that only in the COAST-V were MRI of the sacroiliac joints and assessed, and not in COAST-W. So they could not pull data from both trials stratified by MRI of the sacroiliac joints. And when we look at the MRI of the spine, there is not such a clear difference, especially in COAST-V, between both groups. And I think this also is in line with what we know, that MRI of the sacroiliac joints are really most important when looking at the presence of objectivable information.
Okay, thank you, Sofia. So now we can move on. Our second paper is Impact of filgotinib on sacroiliac joint magnetic response imaging structural regions at 12 weeks in patients with active ankylosing spondylitis, Tortuga trial. As a study background, in the phase 2 Tortuga trial, filgotinib reduced disease activity, improved symptoms, and reduced spine and SI joint inflammation in patients with active r-axSpA. The aim of this follow-up to Tortuga was to assess the effect of filgotinib on MRI measures of structural change in the SI joint in patients with active r-axSpA and inadequate response or intolerance to at least 2 NSAIDs. As the methods, patients more than 100 were randomized 1-to-1 to filgotinib 200 mg or placebo, both QD for 12 weeks. MRI scans of the SI joint were analyzed for erosion, backfill, fat metaplasia, and ankylosis using SPARC, sacroiliac joint structure score, SSS, at baseline and at week 12. This endpoint was change from baseline in SPARC SSS total erosion, total backfill, total fat metaplasia, and total ankylosis scores at week 12, and proportion of patients with a decrease, increase, or no change in structural region score, including erosion, backfill, ankylosis, and fat metaplasia at week 12, according to baseline SPARC bone marrow edema, and correlation between changes in structural regions and the clinical parameters. Number of patients with erosion who develop backfill at week 12. Then I'm going to present the results. MRI scans from 87 patients, 48 filgotinib and 39 placebo were evaluated. At baseline, there were no notable differences between filgotinib and placebo for any MRI structural region types. From baseline to week 12, filgotinib was associated with a significant reduction in SI joint erosion score and an increase in backfill score versus placebo. But no significant differences were observed for ankylosis or fat metaplasia. In the subgroup of patients with a SPARC bone marrow status score at least 2 at baseline, filgotinib group, backfill increased in 36.4% of patients and decreased in 4.5% of patients. In placebo group, backfill did not increase in any patient, but decreased in 13.6% of patients. And treatment differences for erosion, ankylosis, and fat metaplasia were not significant. And there were no significant differences for any of the structural regions in the subgroup of patients with a SPARC BMO score less than 2 at baseline. At week 12, the change in SPARC MRI SI joint inflammation scores correlated positively with erosion scores, but negatively with backfill scores. Finally, no significant correlations were observed between erosion or backfill scores or ankylosis or fat lesion scores with any of the clinical endpoints assessed. As a conclusion, the significant changes in MRI structural regions in the SI joint by week 12 showed that tissue repair process is induced soon after initiating treatment with filgotinib. This could have prognostic implications for development of ankylosing. So thank you. Sofia, do you have any comments?
Yes, certainly. So I think it's very good to see, a JAK inhibitor with demonstrated effect on structural damage as measured by MRI. As you know, in the field, we are still having some discussions on what is the best way to measure structural damage progression, and it's methodologically is a challenge how to measure it specifically in r-axSpA because it's a slow progression. Traditionally, we have been focusing on axial damage of the spine and using radiographs, but that takes a lot of time before we can really see damage and therefore look at the effect of an intervention on it. So we are seeing more research moving it forward to MRI, which in an earlier phases can detect changes. I think it's very positive to see that treatment can have an effect on those changes. I think in the next month and years, we will see more research coming to confirm hopefully to us that the MRI and these changes that we are seeing demonstrated on MRI really are valid in terms of when seeing them later in radiographs. If that's the case, then we can confidently use MRI as a sign of structural damage in early trials and therefore demonstrate effect modification, which has been, as I mentioned, a struggle in r-axSpA. So I think these findings are very positive and very important in the field to have this type of research. And I think also good for our audience to know about this, that treatment can really have an impact on structural damage in r-axSpA, which is very important.
Okay, thank you for your comments. Yes, previous EMBARK study showed some similar results. And in this study, very early structural changes were confirmed. Then my question is, I wonder, backfill is a good process or a bad process? So how do you think about that?
Yes, I think that's also an ongoing discussion. We obviously want to avoid, actually it all starts with inflammation. We want to avoid inflammation, and later we want to avoid damage resulting from inflammation. So it's better to not leave the process move so far, of course, and hopefully withhold it in an earlier phase. I would say that the precise exact meaning of backfill is still under discussion in the field, and it's difficult to be able to at the moment give you a definitive answer on that.
Thank you. And correlations between SPARC SSS and clinical assessments were not described in this paper, although they were indicated in the methods section. So I'm looking forward to seeing those results in the future paper. Okay, thank you, Sofia.
Okay, thank you very much. And thank you all for joining us for this inaugural r-axSpA podcast brought to you by the CSF. We really hope you enjoyed it and found it useful. If you did, don't forget to subscribe to our channels on YouTube, SoundCloud, or wherever you get your podcasts from, so that you don't miss any future episodes. If you want to read more about what we've discussed today, head over to the cytokinesignaling.com, and where you will find detailed summary slides of each of the papers. See you next time.
See you.